Hello, good morning, students, and namaste. And I hope you all are doing very well right now. So, in the today's class, we'll be learning about the ARDS and the COPD as we have discussed, and hopefully, this shall be a very interesting class for all of you. We'll be discussing very new concepts again, and I'll just recapitulate what we have done earlier. So, we did something about the very basics of what's exactly a normal physiological respiration is, what's ventilation, what is a negative pressure ventilation, what is a positive pressure ventilation. You also know about what's the different, how does the ventilation affects the heart, the effects of what's PEEP, what's the PEEP, peak expiratory, the peak end expiratory pressure. You also know about the tidal volumes. You also know about the normal vent settings. So today we'll be discussing about, now we'll be coming to the basic, the pathologies, which is the ARDS and the COPDs, very, very common settings, very, very common conditions we see in an ICU settings. COPD is very, very common. We also see so many patients of COPD. So we'll be discussing that. Okay. So what does ARDS and COPD means? So ARDS, first we'll talk ARDS. So A is for acute. So what does acute means? A sudden onset. Respiratory distress, so that the patient is having breathlessness or dyspnea. And the syndrome. So whenever we talk of syndrome, majority it's secondary. So and while when we talk of COPD, it's a chronic. So chronic is that's an insidious onset, means it is taking place from a very long time. You have a, like, if you go it, like, probably the patient may be having some problem since like 10 years, 20 years. Obstructive, so it's blocking the air path, and disease, and it is a primary. Okay, so when I talked of obstructive, so there is one thing which is known as restrictive. So I'll just talk about in brief in that. Okay, so obstructive and a restrictive disease. So what does this obstructive and restrictive means? So in an obstructive disease, there is obstruction in the tracheobronchial tree. So let's consider that right now we all are in a lockdown, right? So in a lockdown, what happens is, so you cannot work because you are at home. Okay. But if you take your car out, there is no problem in the routes. You can just, the roads are empty. You can zip through the roads like anything. So that is there, that is a restriction. So you are kind of restricted. Your work is restricted. You cannot go out. You cannot work. Such similarly, in a when you talk of an alveolar disease, when the alveoli cannot expand, so whenever there is a problem of expansion, then that is known as restriction. You feel restricted as if someone has bound you with a kind of a rope. You cannot move. Your body is not able to move. That's known as a restriction. But what is obstruction? Everything in this lung is fine. Everything. So the alveoli is perfect. So the gas exchange is perfect. But the problem is this route. This route is somewhat blocked. So in a way that the air which goes in, it cannot goes in or it cannot go out. So that is a problem in obstruction. This is a major difference between an obstruction and a restrictive. So you can say, in a, let's say if you have a curfew, so you can go out, but at every road you have like police standing. So if you just take out your car and you cannot move, then that is a obstruction. But you can just move out of your house. You can just go in front of your to your shop, so that you can move. That is then, but you cannot drive your car. So that's an obstruction because roads are bad or roads are blocked. But in a restrictive, you cannot move out. But if you happen to take out your car, that can go very easily. So that's a restrictive. So we discussed about that. Now coming to the next part, the disease pathology in ARDS is always alveoli, while in a COPD, the disease pathology is a tracheobronchial tree. Again, the whole portion where actually gas exchange is not happening. So similarly, the main pathophysiology in an ARDS is a gas exchange. So the problem occurs at gas exchange. While in COPD, the main pathophysiology is ventilation. The patient is unable to properly ventilate. So the problem is in inspiration and expiration. The reason for getting a patient is ARDS or the whole lung getting involved is a cytokine storm due to abnormal immune response, while in COPD it's the chronic inflammation. In any disease in the body, anything, which is acute in nature, by default will always have a very high mortality rate because the body cannot compensate. Similarly, that's why when we'll be discussing about acidosis, or probably we'll be discussing some portions today as well. So whenever there is a acute setting, even on an ABG, if a patient get a acute acidosis and there is no compensation which is occurring, the mortality is actually pretty high. Similarly, whenever there is a compensation, your body tries to balance it out. So if you give anything, if there is a time, then the mortality is low. And the best example I think is probably is a myocardial infarctions or a atherosclerosis. Okay. So in an you all know that with over a period of time, you get coronary arteries, they get atherosclerosed with time. So in an old age people, so if it occurs slowly, what happens is there is a development of, you have collateral development. So that is why if a patient of old age gets a MI or a myocardial infarction, or there's a complete blockage, the chance of survival is very much. They actually don't die. They may actually just develop, probably they develop into a CHF. While if the patient has there is a accelerated atherosclerosis which has occurred, so if it's a patient who gets that in a very young age, the collaterals are not developed, those patients when they get MI, the chances of death are very high. Okay, so similarly, whenever there is an any acute setting, the death is always very high. Patient get a very high mortality rate and a very early death. Similarly, in COPD, of course, death occurs in COPD. It's the third most common cause of death right now. But again, when you see these patients are already at a very late age. So mostly around 60s, 70s, you will see. Okay. So now let's talk about ARDS. So the new term which is being used is a acute lung injury. So the new term which is being used is acute lung injury. What happens? The whole lung, especially all the alveoli are involved at a go. So I just draw what happens exactly in a ARDS. Okay. So what happens in an ARDS? So the best example what I can say is, let's say we have a tree. So in a tree we have the trunk and we have the branches, and at the end we have the leaves. So all the work is done by, all the food is being made by the leaves. What if in a single go all the leaves drop down? What happens? Will the plant survive? No. Of course, this plant, when we talk of in a normal tree, what happens? They have a lot of stores, but here we are not talking. Similarly, what will happen if all the alveoli are not able, if are at a go, don't work? What will be the problem? Of course, you cannot breathe in. Like even if you breathe, the problem is there is no gas exchange. If there is no gas exchange, what will happen? The oxygen will start going down, the CO2 will start getting up, and you will die. So that is a major problem in ARDS. Exactly that happens. Now, why this red? The problem with ARDS, and that's why it is called acute lung injury right now, because I explain you why right now we are using term ALI rather than ARDS. The first thing is a respiratory distress. When we talk of a respiratory distress or acute onset dyspnea, it can occur even in, let's say, if a portion of a lung, let's say if this portion of a lung is also involved, a major portion of half of a lung gets involved by any condition, then also you can actually have an acute onset of respiratory distress. But then when we talk of ARDS or acute lung injury, the thing is the whole lung, both the left and the right lung, and almost all the alveoli should get involved. That is known as a ARDS. Okay, so that's why the better term right now what we use for older ARDS is ALI, acute lung injury. So, in a common sense, can there be any single lung condition which can cause actually the whole lung to involve at the same time? Just think, and you'll come across, okay, you don't actually, you don't get to know, okay, the chances are actually very minimal. The only one condition you will see when the whole lung is involved is, you must have read that it happens in pediatric patients when there is decrease in the surfactant levels. Okay, where you need to give bovine surfactant, so the premature kids, they develop a ARDS. So again, the problem is not the lung, but the problem is the surfactants. Okay, so that develops into ARDS. The whole lung gets involved. The whole lung doesn't have the surfactant. But that's why when we talk of ARDS, it's a syndrome, and so it's secondary. So the secondary is the problem is something else. You may develop ARDS with due to septic shock, and I just mentioned you can have due to you can develop due to septic shock. And the most important thing I mentioned, the abnormal immune response. So basically ARDS, you can say, is a kind of a hypersensitivity reaction which has occurred specifically in the lung. So that hypersensitivity or hyper reaction of the body has actually affected whole of a lung. So I just mentioned about abnormal immune response. And I also mentioned that it's occurring the most the main pathophysiology is the cytokine storm. So let me just explain a bit what does this mean. Okay, so let me just tell what is a normal and an abnormal immune response. So the normal immune response means, let's say in a country and we get a terrorist in a city. So what is a normal response in an army? You get to know, okay, this these particular 5-6 terrorists are present in this locality and this building. What should be the normal response? What you'll do? The thing will be, what the army will do is they have one option, that to kill the terrorist, what they'll do, they'll cordon off that specific area and then they'll do all the actions. So similarly, in a pneumonia, where there is a bacteria, what happens is, let's say the bacteria actually entered this area. So we have a bacteria which has entered this area. So what does the body do? What did the body did is, they cordoned off the area and the inflammation was seen only in this area. And so this present as lobar pneumonia. And what do we see? Of course, in a lobar, a lobe is involved. You don't get the whole lung involved, and you only see the consolidation in this much area. So all the actions, so you have all the neutrophils coming in and killing and all these things is occurring not in the whole lung. So the respiration is preserved in rest of the area. So this is known as a normal immune response. Now, what is abnormal? Abnormal is a condition. Let's say the army comes in and they get to know, okay, there are certain terrorists, they are hiding at this place. So what they decide is, okay, the terrorists shall not kill the citizen. So what we do, we blow up whole the city, let all the citizen gets killed by our effort, so that they cannot kill, right? So when inflammation, when the army itself kills everyone to protect, to try to kill the terrorists, that is an abnormal immune response. So the in COVID-19, when you talk of COVID-19 right now, those 5% people who are actually dying, those 5% who are actually getting really sick, are because not by the virus but by the abnormal immune response. Now let's discuss what are the conditions where you can get an abnormal immune response. So let's say if a country who doesn't know how to handle a terrorist, where there are no terrorist activity has ever occurred, or they have never done a specific training for that, what they will do, they'll not understand and they'll probably do a very, very cautious thing and they will cordon off the whole city. Okay, they'll block the whole city and they'll block everyone, they'll block everything. Okay, but if a country, if a army is very used to getting very frequent terrorist attack, what happens is they becomes evolved. What happens is they become evolved, and when they become evolved, they know, okay, if this particular building is affected, I will only attack this building, and we'll then do the next portion, that is the various search operations and all those things which happens. So they'll just do a very specific area. So evolution of a immune system is very important, and that is a reason the extremes of ages, the pediatric age group or less than 1 year, they are more affected by it because their immune system is not evolved. They have not seen so many viruses. Similarly, in elderly, this happens. So in elderly this happens, in elderly as well. Now in elderly there's a one more reason why this happens. I'll just discuss the elderly and the immunocompromised state. So in an immunocompromised state or even in the elderly, this T4 levels, this actually starts to go down. And the T4 is basically the brain of the immune system. T4 decides, okay, how much response to do. Now what happens? So let's consider if a country has a very weak army or doesn't have a lot of things, and so they also don't know how strong is the terrorists are, they don't know because the terrorists are new, they don't know. So what happens is, what they do, the army do is they deploy everything they have because they are not sure, okay, whether they can, if they send 100 people, will that be enough or not, because they are not sure, because they inside they know that we cannot fight it. So that exactly happen in an immunocompromised state, or when the T4 is less, so when the brain is less, they decide, okay, there is some intruder, do whatever you have, we'll do, we'll kill with anything we have, we'll spend everything on them and we'll do anything, but we'll kill them. So that's a very high immune response. So the body doesn't think what damage it will have. That's why it is always said, whenever there is a war, it's for nobody's benefit. It actually causes more harm than good. So similarly, whenever such kind of things happens, whenever there is a when there is brainless kind of immune response which occurs, where they just blows out everything to control it, then actually it blows out itself only. So that's kind of a suicide attack. So what you read in the lysosomes, to kill the bacteria, you actually kill everyone, to kill everything. Okay. Okay. So now you know what exactly ARDS is. So whenever there is very high inflammation, there is also hyaline deposition in the alveoli. So since all these patients will be in the ICUs, so and we always do an ABG. So what we will find that these patients will be having a very high CO2 levels because there is no gas exchange, and there will be decrease in the oxygen levels. And because the patients will be having a higher amount of CO2 levels, what the patient will be trying to do is, patient will be trying to ventilate fast. So there will be a kind of a shallow rapid breathing which will be occurring. So now let's what you should do and what you should not do in this patient. So basically the common concept what we discussed is that the CO2 is affected by the respiratory rate and the tidal volume, and the PO2 is affected by the FiO2 and the PEEP. So if the PCO2 is high, what you will think is, okay, what I'll do, I'll increase the tidal volume, so that what will happen is the CO2 levels will go down and we'll increase the PEEP. But let me tell you what exactly happens if you increase the tidal volume. Okay. So if you increase the tidal volume here, what happens is, so this is an alveoli. If you increase the tidal volume, this will become more, and similarly if the respiratory rate is more, this will be going like this and this. Similarly, this will become flat and big. It will become swollen and become flat, swollen and flat. But exactly what's the problem? The problem in ARDS is inflammation. So the problem is inflammation, and whenever there is inflammation, and there is, when you do this, what does actually TB does, it increases the shear stress. And what does this happens, whenever there is increase in the shear stress, it leads to increase in inflammation. So basically if you try to increase the tidal volume, what happens is, the problem what occurs here is, you actually it tend to cause more harm than good. So you should never increase tidal volume. Rather, the guideline says that the tidal volume should be reduced to how much? To 4 to 6 ml per kg. And this you all know, ideal body weight. So normally what was normal, what we discussed, normal was around 7 to 8, and we have to go down to 4 to 6. So you have to actually reduce the tidal volume. Yeah, but what we actually do is, we of course we can increase the PEEP. What happens when you increase the PEEP? So you all know about PEEP. So this alveoli remains open. So there is increase in recruitment. So this increase in recruitment actually leads to increase in oxygenation. So here, the even though the patient wants to take more breath, but what you do is you just try to increase the PEEP, and you don't actually increase FiO2 too much. You can increase slightly to increase oxygenation, but you cannot, because then there is a risk of oxygen injury itself, the free radical injury. So this is what is a common vent setting when we do go for a ARDS. In the only one thing you should remember, do not increase the tidal volumes. Okay. Similarly, it has been found that if a patient is given ventilation 12 hours in prone position, it has found to actually improve survival. Though there are various theories behind it, but still nobody knows exactly why it happens. So it's better that you give these patients ventilation in a prone position for at least 12 hours a day. Okay. So now we go to the